Next, next presentation will be the clinical carotid plaque imaging by Kevin DeMarco. He's from the Walter Reed National Military and Medical Center.
Thank you very much. First, I just have to say how much fun it is to be back in the room with everybody. We were just talking how we can't believe it's been since 2019, and we're all excited to be back together again and talking and collaborating in person. And I'd also like to thank the organizers for the invitation to come and discuss with you my experience with clinical carotid plaque imaging, and as has been kind of this scenario for the whole morning and afternoon session, I will be comparing and contrasting MRA and CTA. I'd first like to start off with acknowledging research funding support and the DoD disclaimer statements. Current guidelines, except for one, which I'll mention in a second, worldwide do not include anything about plaque imaging in the criteria of how you manage patients. It's strictly about stenosis. The one exception was the 2018 update of the European Society of Vascular Surgery and Cardiology, where they said you could consider an endarterectomy if you had one or more imaging characteristics. So this I take as our action, our call to action as a society is we need to work on this, because we've had a decade of excellent research showing that plaque imaging is a much better predictor of recurrent stroke than stenosis measurements, and yet it's not in guidelines. And as Mahmoud was just showing us with his study, it's not even on the in the ballpark range of our referring clinicians' thoughts. So I kind of look to us as we need to really work on that. Luca Saba organized a nice two-day session in Italy just before COVID, and this roadmap consensus paper was an excellent summary of the discussions over a two-day period of time, and in particular the suggested roadmap, and we've heard the same the same ideas by other speakers this morning, is clinical carotid plaque imaging is about phenotypic classification and risk stratification. And we've heard the discussions, we've seen some excellent presentations talking about what we understand: large necrotic core, thinner ruptured fibrous cap, intraplaque hemorrhage. But we need to help our clinicians get this included into routine imaging so they can use that information to manage patients. Some novel new features you've seen introduced, both from quantitative imaging from MR, and I'll show you an interesting concept about what they call virtual transcriptomics from CT imaging. And as far as risk stratification, give your clinician an idea of how urgent the change in the therapy is based on what we're seeing with plaque imaging. This excellent study by Dr. Schindler got patient-specific information from these 7 studies where they found just the incidence of stroke, and again confirmed the 10-fold increase, a hazard ratio, with the presence of intraplaque hemorrhage, whether you had symptomatic or asymptomatic carotid stenosis, where the simple stenosis measurements didn't aid. In my own clinical experience, I've definitely seen this. This was a middle-aged person presenting with transitory right arm and leg weakness. The duplex ultrasound said less than 50%, but they sent it to us to characterize, and we can see vulnerable features or high-risk features. We can see the penetrating ulcer. We can see the ruptured fibrous cap with juxtaluminal thrombus right at the level of that ulcer, and the clinician understood why the person was having symptoms, and we aided their diagnosis. We do know from multiple studies, serial studies, that if you have plaque hemorrhage at baseline, and that's what this T1 hyperintensity here on time of flight represents, even when you're treated with statins, you continue to progress with the amount of intraplaque hemorrhage and total plaque wall. So this suggests to the clinicians maybe we need to do even more intensive lipid-lowering therapy, or perhaps we need to add something more than simple delipidation to the protocol. Maybe we need to add anti-inflammatory medication. We also know from all of these randomized clinical studies that the presence of a necrotic core or a thinner ruptured fibers cap is also associated with intraplaque hemorrhage. I'm sorry, with recurrent stroke or TIA. And we can do more than just say, what is your risk? We can say, is the medication that you're now giving the patient making them better? And so many studies have shown it. I'm showing the example from Dr. Shao, the University of Washington, where these patients had necrotic and non-enhancing necrotic core at baseline, and then they were placed on statin therapy, and we see this continual decrease with an eventual plateauing out of therapeutic advantage at about 3 years. So we know what we can expect over time, and we can tell our clinicians, is this working or not? And I want to share with you a couple of recent examples where one case it worked and one case it didn't. This patient presented because of some pain in the parotid gland, and that wound up being fine, but on the CTA done for soft tissue, we saw what looked to be a large necrotic core. So I called the patient back with the clinician's permission, and we did our multi-contrast carotid plaque imaging. And this is the standard clinical stuff, not the high-res research coil studies, but you can see here a very large necrotic core. And so the patient was placed on statin therapies. There was some challenges for the patient tolerating the statins. And they were worked through that to clinicians, and we can see a little over a year later that necrotic core decreased. So we can say, to the clinician, in addition to lowering a value on a lab sheet, you're helping your patient. Here is the opposite example. This person presented with a non-ST elevation myocardial infarct, had documented 3-vessel coronary artery disease in 2014, but the duplex ultrasound only showed mild stenosis. 2 years later, the patient presents, and now we can see a moderate carotid stenosis. So the patient progressed despite adequate medical therapy. And as you might guess from the way I'm sounding negative about this study, the patient did not have a good outcome. A year later, presents with acute stroke, ipsilateral, and you can see what's happened: rupture of the fibers cap, intraluminal thrombus. So the left side stayed stable and never had any high-risk plaque features. So the discussion points here is progressive stenosis despite medical therapy portends a poor prognosis, and we need to let our clinicians know that. So carotid plaque imaging can give additional risk stratification, and we can tell the clinicians whether their change in medical therapy is beneficial or not. And then the last couple of minutes, I kind of want to go over with you some of the new and exciting imaging biomarkers, some of which you've heard discussed already today. This is from that multi-institution study that Dr. Albeck just was mentioning, where we use these neck-specific shape head coils combined with Q-match, and we'll also be using the Arizona technique and quantifying the plaque features. At the beginning, we're going to simply say, yeah, can we use it to say that's necrotic core hemorrhage? But I think the more exciting thing is, will this quantitative information and AI analysis of how the patient does down the road lead us to even more information than what we know today with our regular imaging? And not to forget CT. This is a very interesting project that was presented in ATVB last year, where they wanted to get a non-invasive assessment of biological and molecular features of carotid plaque from their imaging analysis of CTA. So they're going through a variety of scales of size and going from what the plaque looks like and then using that to predict the per-patient molecular signatures for atherosclerotic phenotyping. So they're doing phenotyping for the future in a different way as well. So both fields are progressing. And here's the various biological processes that are routinely determined by CTA morphology. And the fundamental possibilities here is we can understand why the atherosclerosis is happening in that individual patient, and then maybe offer individualized therapy based on that information. So some new exciting things that are potentially down the road. So what I tried to do was kind of go through with you current guidelines. The big thing I took from the presentations I heard today is we really need to help our clinicians be able to understand the additional risk stratification. And one of the really easy, low-hanging fruits, John Houston and I have been working, and anybody else in the room who's interested, on offering downloadable protocols that the clinician, that the radiologist at each site, no matter which manufacturer, which imaging 1.5 and 3T, can just plug in an SMRA certified protocol, so we get standardization, ease of use. The sequence is usually 4 minutes. And I think if we can make this more prevalent in the community with standardized protocols centered by our society, we can move this idea of adding plaque imaging to a routine carotid MRA. And that's how we build MRA business, because we add value over what CTA can do. And again, CTA has these interesting opportunities with transcriptome. And then lastly, risk stratification. How urgent is medical therapy needed? Thank you very much.